They're all important.
Huge. Every single one.
All right, let's delve back into your AMS stuff, okay? Way back when we talked about immunology and our immune cells, okay? If we have innate and adaptive, right? So innate is our first line of defense. That is, if you will, in the hospital, these are the rapid response teams, okay? So you get an invader, they come, they don't have to be pre-educated. Okay, the adaptive is the ones who are pre-educated. And so the second time that they don't really recognize it the first time, or they have to get to know the person in order to say, oh, no, this person's no good. Okay. And next time you come, you know, bar the doors and everything else. That's your adaptive immune system. Okay, it's typically delayed. However, the delay is really for the first encounter. Subsequent encounters, it can come up to speed very quickly and respond. Okay. The innate is absolutely necessary for adaptive. The main mediators between adaptive and acquired, or adaptive and innate, is the dendritic cells. And these are key players that kind of communicate between the two different components of the immune system. And to have a full complement of immune cells and everything else, we need both to be functioning properly. Now you don't want to work.
Worth a shot.
Yeah, that's
It
one of those
worked.
days. Okay, so let's just take a look at some of the features, okay? This, and features are only on the far left, okay, of the columns. Your innate, okay, is in the middle, and then your adaptive is to the far right from you. So left, middle, and right, okay? And so they divide these in terms of your time of response. Again, innate is immediate. Okay? Your adaptive is going to depend on the exposure. The first time, it's delayed. Second, it's immediate because now it has memory and it can produce those antibodies, those IgGs, IgM. Diversity. Your innate is very limited to classes or groups of microbes that have specific very specific elements on their surface that our immune system recognizes as foreign. Now, if they have that slimy coat that covers those proteins, all bets are off, because that's one of the hiding mechanisms, one of the evasive mechanisms. As far as the adaptive, the diversity, very, very large, but it's very, very specific for each antigen. So each microbe is going to have its specific antigen that our adaptive immunity can then hone in on after the initial exposure. As far as microbe recognition goes, you know, again, there's general patterns. There's similar sugar molecules or proteins, okay? And it's not specific to each pathogen. It's just, it is kind of it's more of a general characteristic of microbes. Okay, and whereas the adaptive is very, very specific. As far as non-self recognition, both are supposed to be able to recognize non-self. Okay, and As far as response to repeated infection, the innate, it's gonna be similar with each exposure. It doesn't ramp up because you've been exposed to it before. However, the adaptive will have a boosted effect because now it has those memory cells that can rapidly produce the immunoglobulins to attack it. As far as the defense, we talk about defenses, the innate is all of our, epithelial cells, regardless of which, tract it's in, that is a barrier, it's a defense. It's innate, part of our being. So are phagocytes, so is inflammation, and so is fever, all innate. Adaptive has to do with the cell killing and tagging antigens by antibody for removal by some of the phagocytes. Cellular components, you can see the innate includes all your phagocytes, so your monocytes, your macrophages. Monocytes become macrophages in the tissues. Okay, so remember that connection. Your neutrophils, your natural killer cells, and your dendritic cells. Okay, and you can see the crossover here. So on the adaptive side, you had T and B lymphocytes, you have some macrophages, and you have dendritic cells and natural killer cells. So there is some crossover there. And then as far as the molecular component, your innate has various cytokines, which we'll talk about in more detail, complement proteins, which we'll talk about in more detail. There are acute phase proteins, which we've talked about. Okay, and then we also have soluble mediators. Talk about those as well. As far as the adaptive, it's, antibodies are the big thing. However, there are also cytokines, and it also activates the complement system. So, you can see some of the differences and some of the similarities here. Okay, as far as your cytokines go, you have cytokines and chemokines, and I know we've used those terms. Cyto means cell, okay? Chemo is a chemical, okay? So the cytokines are substances that are soluble that will actually, they can kill cells, they can destroy cells, and they can communicate with other cells. They tend to be very low molecular weight, and they can be both pro-inflammatory and anti-inflammatory. Chemokines is it's a subset of cytokines, so they're just a smaller kind of molecule. It's a smaller protein molecule, so it's a subset, and it can attract other white blood cells to the area. It can, where there's been injury or infection, it can also bring them to the lymph nodes, the spleen, your Peyer's patches, the tonsils, all your lymphoid tissues. Okay, and so they're natural attractants to bring in more white cells. Okay. And I don't expect you to memorize this whole chart that's in your textbook. There are, and we went over this in AMS, there are multiple interleukins. Okay, and you can see they come from different white blood cells. Some of them are secreted by macrophages, some are secreted by lymphocytes. It didn't change. I give up.
Yeah.
Okay. So you can see that there's different ones, lots of them. You have interferons, which we talk about, there's alpha, beta, gamma, interferon. There's tumor necrosis factor alpha. There's, we have all the colony stimulating factors, some of which will stimulate bone marrow production of white cells or specifically granulocytes, et cetera. And it is good to read through these and understand them in general, but I'm not going to ask you specifics. You're not going to be immunologist. Okay. So overall, your interleukins, you can see that this general information I expect you to know. So they're produced by macrophages and lymphocytes. And their whole purpose is to really enhance and regulate the inflammatory process. Okay, and some have much more targeted, responses. But they are an important component of our immune system. Your interferons, I have them spelled out, alpha, beta, and gamma. Okay, and so alpha is extremely active. These are mostly macrophages and T lymphocytes. And so your interferons are targeted towards viral infections especially, and they do have some modulation on the inflammatory response. Your alpha, which is actually produced by macrophages, okay, this is an important first line defense. It's pyogenic. And if it goes unchecked, or there's excessive amounts of interferon alpha, this is one of those triggers that can actually stimulate the beginning of DIC. So you've heard about DIC, you know what it is, but how do we get there? Sometimes it's this interferon alpha. Okay, a pro-inflammatory that can start to stimulate the coagulation cascade, which then can lead to, microthrombi and consumption of all your coagulation factors. Interferon beta, this is also produced by macrophages, and then gamma is your T lymphocytes. And so realize that these particular cytokines, they're meant to be brief. They're meant to be very self-limited and targeted. They're not stored. Most of them are not stored in your lysosomes. So you're not going to get this continue out like massive release. Okay. And there is some redundancy and crossover so that they can be produced by different cells, and it allows for a stronger immune system. So problem is when it goes unregulated. Okay, those are your major cytokines, your chemokines. We're looking at, again, very small protein molecules. And their main goal is to attract other leukocytes to your primary site of action and include those lymph nodes and spleen, et cetera. It's subdivided into 4 overall classes. There are 48 different substances that have been identified. Too much to remember, not that important at this point for you all. Okay, the important thing is 2 of the classes, the 2 that are elaborated upon, are the ones that are most active, okay, when it comes to the inflammatory response in the immune system. And you can see that class CC attracts monocytes, lymphocytes, eosinophils, okay? And then class CXC is going to attract neutrophils. So you can see where they would play a role depending on the type of infection or inflammatory response. Okay. There is some communication, you know, and it has to do with protein receptors, especially the G-coupled protein receptors on the surface molecule. And some of these can be inflammatory and some can be inhibitory. So it is a matter of a balancing act. Okay. In uncontrolled pro-inflammatory, it can lead to some of these chronic diseases. Okay. There's still a lot, this is all relatively new information. And so there's a lot still being learned about it. Your colony stimulating factors, very much a subset of cytokines. Okay, and like your chemokines, this is very, very specific. They're named for their target cell type. So you can have granulocyte colony stimulating factor. Okay, GCSF. You can have GM-CSF. And so just know that these can be released from your inflammatory cells in order to stimulate the bone marrow or tissues in the area to produce more cells. Okay. Looking at your innate immunity. Okay. So innate is our first line defense. So for those of you who are visual learners especially, we talk about our epithelial barriers. They provide a barrier for our, they provide a barrier. It's dead. There it goes. It's very weak.
Wasn't working well this morning either.
Wasn't working this morning. Anyway, up top. Okay. We'll do that white thing. You know, it's a barrier to microbes. Okay, and as long as you have intact skin, the bacteria don't necessarily have a portal of entry. Okay, so that is one of our barriers. You have monocytes, which become your tissue macrophages, your neutrophils, your phagocytes. Okay, neutrophils and monocytes, macrophages are all phagocytes. Okay, they can engulf and destroy bacteria once they invade. Okay. Your natural killer cells, they have some of those receptors that will bind specifically with these bacteria, and they can release cytokines and just dissolve them. And we can also activate complement, which can form a complex with some of these receptors on the surface, which then leads to either antibody engulf or destroying it, or market for elimination by one of our T cells. So just a little bit more in depth and a reminder of your epithelial barriers. Okay, these are both physical, mechanical, and biochemical barriers. Because your skin, in addition to the cells, also produces, you know, that layer of keratin. It has a higher salt content and an acid content, and the ability to produce lysozyme. Some of your mucous membranes, with your GI, your GU, your respiratory tract, again, more epithelial cells, they produce mucin, and it's, you know, and all of that helps. It has cilia, all of that helps with elimination of pathogens. Your lysozyme, which is found, this is hydrolytic, okay, and it's found in your saliva and in human milk. God bless you.
Thank you.
And then complement, these are precursors, 20 different precursors to enzymes that are in the blood that can get activated, okay, by antigen antibody complexes, and they'll cause bacteria to clump together for easier phagocytosis. So you can get a whole clump of bacteria and it just takes care of the whole clump. Your stomach acids, they're protective. Okay, and defensins in the GI tract as well, so there are some secretion of immune factors in the GI tract. Looking at some of your cells specifically, these just go through what we've already talked about. Okay, so neutrophils, monocytes, primary Pac-mans, your dendritic cells, they bridge between innate and adaptive, your NKCs and your intraepithelial lymphocytes. They have direct killing ability, as well as the ability to produce cytokines, which again, excitatory and inhibitory, so they can attract more, they can, more white cells, and so they can also secrete cytokines, and so they're just natural born killing machines. As far as self-recognition, the top diagram A shows the natural killer cell. And again, this is a depiction, and it has both an activating receptor and an inhibitory receptor. So if it comes in contact with a normal healthy cell, and both of those receptors engage, right, then you don't have any destruction of cells, self-recognition. If, on the other hand, on the lower diagram, you have a virus-infected cell.
Fine, there it is.
So if you have the diagram on the bottom, you see the top, two receptors, it's like a plug and an outlet. You put them both in, okay? You got current, but it's not gonna short on you. Okay? The bottom one, if you only have one prong, something's gonna go here, okay? And it's gonna short circuit. And then it's gonna destroy it. So think of it that way. Two prongs were good, one prong, short circuit. Destruction, electrocution. And so if you only have that excitatory or activating receptor engaged, then it will actually destroy the cell. It'd be programmed to target that cell. All right, and so how do they recognize pathogens? Well, we talked about the different molecules, and so these are called PAMs and PRRs. Okay, and so your PAMs, they're on the surface of the pathogen. They're recognized by PRRs on the surface of the cells. So I'm getting there. Thank you. This is drive me bad in it. Okay, so the PRRs are on your immune cells, right? And they can be pro-inflammatory and antimicrobial. And so they can trigger synthesis, release of cytokines, chemokines, cell adhesion molecules so that they bind together, right? And so some of your PAMs, it's just, like I said, it's just sugar molecules, lipids, proteins, whatever the pattern is, it's this little combination. Okay? It's recognized, it's kind of general, it's a pattern recognition. Okay, and so your PRRs are your pathogen recognition receptors. There's over 1,000 different ones on your white cells. And so when you get that finding, it can result in complement activation, phagocytosis, and even autophagy, but whatever they eat them. Pack it in. Okay, so toll-like receptors are different. They're similar, but they're very, they're glycoproteins that are integral to the cell wall, cell membrane, and they have an extracellular binding site. And that can actually initiate a signaling cascade, okay, that then stimulates other intracellular processes we see these mostly in the bone marrow cells. It is very much important for wound healing and repair. Okay, some other soluble mediators. Okay, as if we don't have enough already, we have soluble mediators. We have opsonins. We've talked about the interleukins, interferons, there's also a lymphotoxin. So opsonins, and you have your acute phase proteins, which we've kind of talked about. We'll go in a little bit more detail, but opsonins are, they are molecules that will actually cover or coat negatively charged particles on cell membranes. So, some of your proteins, some of your proteins that may have a negative charge to them, and they will promote binding with a white blood cell. So essentially, find them as a soluble mediator that will coat these proteins and make them more apt to then bind with the white blood cell for whatever comes next. Okay, and it includes things like some of your acute phase proteins, your lectin, complement, even IgG and IgM can act as opsonins. Okay, so you see that where IgG or IgM, they bind with an antigen, and then it marks that cell for deletion by another one that's like. Okay, as far as your acute phase proteins, the big categories that we talked about, mannose binding ligand is one. The one you're more familiar with is C-reactive protein. Okay, both of those are going to help binding by your innate immune cells and stimulate that immune response, and especially the complement system. So MBL stands for mannose binding ligand, mannose being one of those sugar molecules that are often found on the surface of your bacteria. It's a pretty complicated immune system. Okay, looking at the complement system, and this works with both innate and acquired for adaptive immunity. And it does stimulate various processes, and just again, another way of destroying the pathogen. Okay, and so it's a group of essentially inactive proteins that are in our circulation. Thank you. Do you want to just come up here? And so these are inactive proteins that are in circulation, okay? And also in some of our extracellular fluids, and they're just there. But when you have some of the other stimuli, okay, like your active phase proteins, your MBL, your C-reactive protein, okay, when you have those, it activates complement as well. And once that complement becomes activated, they are essentially proteolytic. So they're going to destroy any proteins that are in those cell membranes or cell walls. And so the whole goal is to destroy the pathogen. There are 3 phases of the response. There's the initiation and activation. Then it ramps up, so it gets amplified. And then the late stage membrane attack. So 3 parallel pathways, how this can occur, which again emphasizes the redundancy that's built into our human being, and that there's a lot of redundancy in there. And so if you're lacking in one, the other two can pick up the, the charge, if you will. So your classical pathway is the one that's initiated by IgG and IgM. And they'll bind the C1. The lectin pathway has to do with the MBLs and mannose binding. And the alternative pathway is a direct activation by the microbe. So all three of those pathways can activate complement. Different parts, different components of complement. Remember, there's C1 through C9. Okay. And so because of that redundancy, if you have a deficiency in one, you really don't notice it too much. This is looking at your classical pathway. Okay, as well as your alternative, and then your lectin. So start at the top with classic. You have the antibody, okay, that binds, and then it's gonna activate complement, which then we'll get a little bit later. It'll go into the next phase. So this is the initiation or activation of complement. So the microbe itself can directly activate complement, or get that MBL that then can bind, and that combination can activate complement. So the next phase would be the amplification. So once you get to that C3 in this slide here, it picks up at the top here. And there's different pathways that can complement activation can lead to phagocytosis. It can lead to chemotaxis, bringing more white cells into the area. It can lead to direct destruction, okay? And it can also cause dilation of your capillary beds to allow all of this to seep into whatever the area is that the pathogen is. So it will dilate your vasculature and increase permeability. So that would be the amplification. So it's destroying, it's breaking down the complement, it's dilating the capillaries, and it's drawing more inflammatory cells into the area to help with phagocytosis. So it's ramping up, amplifying the effect. Then that C5 complement goes through and can actually itself target the pathogen, okay, and lead to destruction. Okay, so those are really your three phases of complement activation and amplification, and then destruction or lysis of the microbe. All right, so that's your innate. That is all innate. Okay, without being educated. Questions? Yes, Ashley.
Is the increased permeability to allow it easier for immune cells to get there?
Sure is. Pretty smart, right? Sydney?
Are acute phase proteins, acute phase reactants the same thing?
Yes and no. So the separate is an acute phase reactant, but it's not specifically a protein because it's a sedimentation rate, and it has to do with the amount of proteins and stuff that are in that delays the sedimentation of your red cells. So that is an acute phase reactant test. However, it's kind of indirect, and it's not a specific protein level like C-reactant proteins. Go ahead.
No, that's okay. I'm gonna think on it.
You think on it?
Yeah.
Okay. Think about what a sed rate is.
It would be a negative acute.
It's a erythrocyte sedimentation rate. it
No, I
counts.
get the protein part.
Yeah.
The protein versus the reactant part makes sense.
Yes.
So the
So
acute phase
NBLs
part,
and T-reactive protein are your two main proteins, if you will.
but they're both just responses to inflammation. That's like the baseline of it.
Yeah.
Okay.
You got it. But the only one that we really test for is C-reactive protein. All right. The adaptive immunity. This is our final line of defense. We have our barriers, we have our innate cells and complement and cytokines and all that stuff. Now we get to the very specific, okay, and this gets activated after your innate.
If you should just get a button. Oh,
Okay. This gets activated once your innate has already triggered the inflammatory response.
If you're feeling like
And yes, once it gets
something else to do.
activated, it can target specific cells or organisms. Okay, and it's delayed for the first exposure. It's much more rapid and fulminant for the second and subsequent exposures. Okay, this is where we're talking about B lymphocytes and T lymphocytes. Humoral immunity is our B, which become plasma cells in the tissues. Those are the ones that produce the antibody. Your T lymphocytes are your cellular immunity. Okay, you have T helper, T killer, T regulatory. You have multiple forms of your T cells, T lymphocytes. Okay, B cells, born in the bone marrow, mature in the bone marrow. T cells, born in the bone marrow, mature in the thymus. Okay, so let's talk about antigens. And we talked last week about some of the toxins being super antigens. Well, essentially, you can say that antigen is the same thing as an immunogen. Okay, it is going to stimulate the immune system or some part or parts of the immune system. Okay, you can have large molecules, and you can have small molecules. Our large molecules include proteins, it includes polysaccharides, it includes lipids, free nucleic acids. So it's larger molecules that become the antigen. Pactins are smaller, very low molecular weight, but they have antigenic determinants. Okay, by themselves, they are circulating in our blood. By themselves, they're incapable of stimulating a full-blown response. However, if they combine with a protein, a larger molecule, okay, then it becomes bigger and it can stimulate a response. And an example of that, two examples are urushiol, which is, I can never say that word, but that's the toxin for contact dermatitis, poison ivy, poison oak. Okay, and another one is penicillin. If they bind with a specific protein and you initiate an immune, it can trigger an immune response. And you can see where people can have quite varying expression of antigen response. Now, what do you remember about poison ivy, poison oak? The hypersensitivity reaction, which one?
Delayed.
Type 4, and it's delayed. And what cells are involved? T cells, very good. Okay. Very good. All right, so Here are your cells, lymphocytes. T lymphocytes, thanks. T lymphocytes, B lymphocytes. Okay, again, antigen, organism specific. Your B lymphocytes can eliminate extracellular microbes and toxins and produce the memory or immunoglobulin production. They are classified according to their MHC2 proteins, their immunoglobulin, as well as complement receptors. So there's a whole like cadre of different types of B cells. Your MHC molecules are molecules that are very specific, and they enable your lymphocytes to differentiate self from non-self. So there are 3 classes, and 1 and 2 code for your human lymphocyte antigens, so your HLAs. Again, major type factor for donor organs. Okay, so this is what we really test for, is these HLA, when we look for HLA compatibility. Because if it's incompatible, you lose, it's not going to recognize it as self, it's going to recognize it as foreign, and it's then going to attack it and destroy it. So you have to have that compatibility. Okay, your APCs or antigen presenting cells, we have them, you know, kind of everywhere in our body. And they're able to express both MHC1 and 2, and bind peptide and antigen. It includes your dendritic cells, monocytes, macrophages, and B lymphocytes. So all of these can serve as antigen presenting cells. What does that mean? It means that they can actually bind to an organism and then say, I can't do anything with it, but I'm going to take you to a T killer cell and let that T cell kill it. So it's going to present that organism to another cell that has the ability to kill it. So B cells can destroy some types of microbes, but not all. And so there's all this interaction between these different parts of your immune system. Remember your immunoglobulins. Okay, IgG is everywhere, all body fluids. It easily exits the bloodstream. It can cross the placenta. This is what gives the fetus immunologic protection for the first 6 months of life. Okay, there are 4 subtypes of IgG. Doesn't matter to me that you know all of them, but again, there are subtypes. IgA is mostly in your mucous membranes, so you're going to see it in saliva, you're going to see it in tears, you're going to see it in your respiratory tract, your GI tract, your GU tract. That's where you're going to see IgA. If you just remember anything that has a mucus layer or your mucous membranes, you're going to be good with IgA. Okay. IgM, this specifically is very efficient, and again, it fixes complement, and so it starts that complement cascade that then draws more immune cells to the area. Okay, which is why your IgM levels go really high when you have a new pathogen. And then, but your IgG levels are delayed with a new pathogen because those are specific. And so IgM with complement, that combination is very toxic to some of your microorganisms. It also can agglutinate, cause agglutination. Or clumping. Okay? And if you remember, go back to your hemolytic anemias. Which one uses or is results because of IgM?
Autoimmune.
Cold agglutinin, who said it? Ashley?
I said
Cold
autoimmune.
agglutinin disease. Okay? Cold agglutinin disease. These are your cold antibodies. And you can see the agglutination component, there it is. Okay, so it is capable of doing that. IgD, mostly on B lymphocyte cell membranes, and it will serve as a receptor for antigen. Okay, and sometimes that receptor, it binds, but it can't necessarily destroy. And so then at that point, those B cells can become APCs and take it to a T cell for elimination. IgE, everybody knows what IgE is at this point, right? Allergic mast cells, degranulation, histamine everywhere. Okay, and we know histamine is a pro-inflammatory. It's going to lead to vasodilation. It leads to increased pain. Okay, the pain response. Oops, I guess it didn't go. Let's go. All right. Lymphocytes. Okay, just pictorially, your typical lymphocyte, one big nucleus. Okay, they're smaller than your polymorphonuclear cells. Your B lymphocytes, they can bind directly to microbes. Okay, they can stimulate complement, they can bind with complement and lead to lysis. They also become your plasma cells, which produce antibody. Your T cells, you have cytotoxic, you have regulatory, and you have your T helpers. So you have helpers, killers, and regulatories. And this shows you, this picture is really about how do immune cells participate in an immune response. And it just kind of puts all those different pieces together. So I encourage you when you review to then come back and take a look at this, because you often start with, and this is starting at the top with an APC cell. So your antigen presenting cell. Could that be a B cell? Absolutely. It could be a B lymphocyte. Okay, but whatever that antigen presenting cell is, it's going to take that antigen. Okay, and it's going to utilize some of those MHC molecules, and then it can actually activate your T cells, the helper cell, to either take it to whatever place it's going to go. But there's a lot of communication that's going on in order to eradicate the organism and produce antibody in the process. And then you should remember, this is just your responses. So on your humoral or your adaptive or acquired immunity, you have your primary cell. If you have a naive B cell, you start with a naive B cell, you expose it to an antigen, you're going to get that delayed primary response. Okay, and this is showing like 2 weeks after, okay, the initial exposure. You get that primary response with that activated B cell. The memory cell then remembers it such that, look at the timing of the secondary response. You get antigen and almost immediately you ramp up and you have, exponentially increased antibody production that is then going to hopefully eliminate this microbe. Okay, so we're looking at that timing, the delayed with the first exposure and almost immediate with the second. We're also looking at the volume of the response. All right, let's take a break. And I'll see you back at 5:00. Community and the two different pathways for, destroying my credit.
Show me that again.
And so it just puts it in a diagram for you, summarizes this, and it shows you the different receptors, you know, not that big of a deal. Nothing new that you haven't learned, okay, so that's all this does. Okay, and so, the big thing is, okay, that they do work together. Okay, looking at your lymphoid organs, a lot of stuff happens in these organs that is part of, you look at your spleen, your liver, it's part of your, lymph or particular epithelial system, and a lot of the killing takes place in your various lymphoid tissues. Okay, as far as active versus passive immunity, this is an important concept. You're gonna hear it in emergency medicine. I want to make sure that you understand it. Some got it in the summer and some didn't, so I'm revisiting it. Okay? Active immunity is your immune cell saying, okay, I've seen you before and I'm now producing antibody because I recognize you. And passive immunity is when we give somebody immunoglobulins or antibodies, okay, that are from somebody else. Okay, a fetus has passive immunity for the first 6 months of its life. Where did the fetus get the antibody from?
Mama.
Yeah, good old mom, okay? Now, you're getting ready to go to somewhere, I don't know, somewhere where typhoid fever is prevalent. Okay, do you want to get typhoid fever to develop antibodies? No, so what do you get?
Vaccinated.
You get the vaccine, which is not a true vaccine, they give you immunoglobulin, like they have immunoglobulins that they can give you depending on the timing. Not all of the things are vaccines. Yes, we can give a vaccine. Vaccine is it active or passive immunity? No, it's not passive. It's active immunity. We're giving you a piece of we're giving you antigen from that pathogen to expose your immune cells to that antigen so that they can manufacture their own. You get exposed to a bat, okay? Everybody's favorite, bats flying in your face, you know, it's all
Guano.
rabies,
Histoplasmosis.
right?
Or histoplasmosis.
Yeah.
Pardon?
Or histoplasmosis.
Yeah. Yeah. Perfect opposite. There's fungal, they're all back guano. However, we're talking rabies right now, okay? You've been exposed. Do I have time to then give you a vaccine to prevent rabies? No, what do I have to give you?
Immunoglobulin.
I gotta give you antibody. You actually get both. So you get the vaccine and you get antibody already. You get IgG. Tetanus. Right? Don't remember when your last tetanus shot was. Okay, and you were outside playing Weekend Warrior and you cut your fingers on a hedge trimmer. Okay?
Yeah, I'll do it. Continuous.
You got organic material. Where does tetanus like to live? In the soil, in the environment, right? So you sit there and you fool around it at home, tough guy, tough girl. You're like, nah, I'll take care of it myself. 2 days later, it's thumping, it's throbbing. You go into the ER. You don't know when your last tetanus shot was. It's been a long time ago. Do you have time to wait? Just get a vaccine. Yeah. So you get tetanus, immunoglobulin, and you get the vaccine. You get both. We give you antibody to fight it. And then also educate your immune system to ramp up production of its own IgG. You get both. You get both. Rabies, you get both. Who has questions? Now's your time. Okay.
Would you ever have an immune response to the IgM or IgG that's given to you or not?
It's always a possibility, but it's less likely. Most of your reactions are very, very mild. Anything else? You learned about RH, right? Rogam? You learned about Rogam at any point? What is Rogam?
Given to a mom,
Oh, yeah. What is Rogam specifically?
given to a RH negative mother with an RH positive fetus.
Right, but why? What is it?
An antibody. Yeah. It's an IgG.
It's IgG. Okay. Now work through why you would give it. Right, so. Now we're getting into the nitty gritty of it. That was the review. Your immunodeficiency means you are deficient in one or more of your immune factors. Right, leading to a weakened immune response. Right? It can be either side of the equation, innate or acquired. That is what we call immune deficiency. You can call it immunocompromised. Immunocompetent means you have a full plate of your immune factors. When we have allergic or autoimmune responses, in either case, okay, it's excessive, like there's a loss of regulation. So it's an excessive reaction or inability to recognize self-antigens in the case of autoimmune. Okay, we lack a regulatory process. So when you have an allergic exposure, you're full-blown anaphylaxis. Okay. And again, we'll talk about that, but it's a whole spectrum. So self-regulation is our body's ability to regulate, to control how much of a reaction, how symptomatic, okay, systemic versus local, okay, and it's really about resolving all that reactivity, that immune response in an appropriate time frame. Anybody in here like get the COVID vaccine and you felt horrible for a couple days, day or, you know? Anybody in here get it and, you know, maybe your arm got a little sore and that's it? Okay, again, very much different responses and it's very individualized. Okay, so we're gonna look into some of the disorders now. So think about, you have all of these cells, all of these different proteins, large proteins, small proteins. If you have a deficiency or dysfunction or lack of regulation in any of these multiple components, the effect that it can have on the body. Anything that is primary is what?
Genetic.
Genetic, very good. I heard it, somebody said it, yeah, actually, yeah.
Spot on.
So. No, I'm on the right slide. I am, if you can come look, I'm on the right slide.
You
I'm
can
just
come
talking about
look.
my head right now. The normal stuff. So, you know. When you have disorders. You've got to think broadly. Most of your primaries are going to present at what stage? I'm saying most, not all, but at what stage of life? Early, good, yeah, early. Okay? Especially when we're talking about the immune system. Do you agree? Yeah, how are they gonna present? Infections, right? Yeah, exactly. Some of your other regulatory or loss of regulation. What do we see? What kind of disorders? Autoimmune, very good, Jackson. Autoimmune disorders. Okay, and if you look at a lot of your autoimmune disorders, which you're gonna learn, I think. You do rheumatology after infectious disease. Which is kind of cool. I think it's rheumatology, or is it endocrine first? Endocrine, okay. I like rheumatology, but, I hate it. Anyway, rheumatology is fascinating to me. However, you'll see that there's, well, in almost all of your right rheumatologic conditions, there's like bimodal distributions. But at different phases, so you might see a big jump in the 20s and 30s, and then again in the 50s and 60s. It's very interesting to me. And what do you think that represents? What do you think that represents? Some of it's genetic, right? Some of it's going to be a genetic predisposition, and then maybe whatever, a virus or something that's going to affect our regulation. And then in the older age group, it's due to those senile senescent immune cells that forget and so that's kind of what it's from, really. So primary, congenital, or inherited, secondary is acquired, and realize that all your white cells are produced in your bone marrow. Your bone marrow needs nutrition. It needs all of its nutritional support for those hematopoietic cells to reproduce. It can't be infiltrated by cancers. It can't, it needs, you need all these building blocks, proteins, iron, you need all this for these myeloid precursor cells to then produce all your granulocytes. You need your lymphoid, line. You've got two different lines there, your granulocytes and your lymphocytes. And so your liver's got to be healthy. That's where the major production of, proteins. If your liver's not doing so well, your immune system goes down. And so always remember that, and you got to think bigger picture. Some of our cancer cells, and cancers and chemotherapeutic agents and what they do and deplete our bone marrow. And so and this is an important slide, so I would probably spend some time on it. you're looking at the disorder and thinking about what each particular component of the immune system does. If you have a B cell deficiency, B cells become plasma cells. Plasma cells produce immunoglobulins. So, do they have anything to do with fungal infections? No. What's important in fungal infections? How do we kill fungal infections? Which cells? Which cell line? T cells. Very good, Helena. So T cells. So no, this is B cells. So if you have a B cell deficiency, you're really looking at a lot of bacterial infections. These are clues. Those protein, those molecules, those antigens on the surface, enteroviruses, polioviruses, but look at all the bacterial infections. If you strep, staph, H flu, well, you know, some of your bad actors. And you're going to be prone to those types of infections. If you have a T cell mediated immunodeficiency, there's those fungi. Those patients are going to get fungal infections. And then mycobacteria, so TB and its cousins. Salmonella typhi, when in the bacteria, and herpes viruses. So if you have a combined immunodeficiency of T cells and B cells, everybody's in the loop. And then complement disorders, we're back to bacteria again. Remember, complement will bind with bacterial sugar molecules on the surface. But this is a good summary slide that kind of hopefully clues you in. These are clues as to what kind of deficiency it is. Your patient presents with, you know, an aspergillus pneumonia. You better look at their T cell levels. If you look at, and what does, when we get to HIV, what does HIV affect? CD4, which are what?
T cells.
T cells. Okay, now, does it make sense that they get things like cryptococcus, meningitis, pneumocystis jirovecii, pneumonia? Okay, they're fungal infections, systemic, and they can, and so that's why, is because their CD4 specific T cells are depleted. God bless you. So your humoral B cells, okay, these are your major B cell deficiencies. And which are going to lead to decrease in immunoglobulin production and all your immunoglobulins. Okay. And yes, you're going to see primarily bacterial infections with these. So you have transient hypogammaglobulinemia of infancy. And so this is transient because essentially it's delayed. And remember, baby gets everything from mama till about 6 months of age. And then they start producing all their own. But sometimes it's delayed, usually a little by a year, 2 years, they're caught up. But they could have this, which then makes them more prone to recurrent infection, especially URIs, even lower respiratory tract infections. allergies, allergic asthma in their infancy. But as they get older and their immune system becomes more mature, then they can actually produce it. Okay, and so it's transient. In the meantime, we just need to support them and treat their infections. As far as primary disorders. Okay, this means that these are all genetic. Okay, inherited. You've got X-linked gamma globulinemia. Okay. So what's that say about males? They only need one X, right? They only have one X. So if they get it, they're gonna have it. They're gonna display this trait. Okay, gamma globulinemia. It means they don't produce any gamma globulin. That's a bad place to be. This is a pretty severe, this is a very severe defect. Okay, and so, thank God it's pretty rare. There's a common variable immunodeficiency. This actually impairs, it's not all or none, but it impairs your B cell differentiation and then antibody production. It can manifest anytime in life. It's associated with both infections and autoimmune diseases, including ITP, your idiopathic thrombocytopenia purpura, as well as your autoimmune hemolytic anemia. There's a few others. They're also at risk for lymphoid cancers, and we treat them with IV, intravenous immunoglobulin. Right, that's a common variable immunodeficiency. Your selective immunoglobulin A deficiency. Okay, where do we say that A is located?
Mucous membrane.
Mucous membrane. So primarily these patients get respiratory infections. They present with a lot of respiratory infections, could have GU infections. And so it is a range. It can be moderate to marked, pretty significant, in the secretions of IgA, and as well as in the blood. Okay, so it ranges quite a bit. And then there's a immunoglobulin G subclass deficiency. So remember I said there are 4 different subcategories of IgG. Okay, this is IG 1-4. And but you can have deficiencies in one or more of the subtypes. So again, most of these are going to be prone to lots of infections, and they're going to be identified earlier. And this diagram just really shows you, again, in the differentiation component, where some of these failure to differentiate occurs. Okay, so it can occur in if it's an A in like transient, it's way over. Is this? It's not going to work. Now it's working. Okay, so it didn't show up. What did I just do? Oh, I changed the slide. New me? You're bad. Okay, so A transient, A is all the way over here. So it's, you know, it's not as big of a deal. B, okay, is here. So now it's not working again. Okay, so A is way over here. B, you're going to see a problem with differentiation there. C is all the way out in the periphery into the plasma cells, and then D is the subtypes. Okay, so these are some of your different immunodeficiencies. And it has to do with your B cell differentiation and where the problem lies. Okay, we talked about secondary humoral immunity, humoral immunodeficiency. So we talked about the liver, that makes sense. But think about things, and we talked about nutrition. Think about burns. Okay, with burns, you lose a lot of albumin. Albumin is a major protein molecule. Is a major transport molecule, and you lose a lot of protein and you lose a lot of plasma. So you're gonna be losing your immune factors by just anything that's circulating in your plasma is being lost when you have burns, significant burns. There's always GI loss as far as, even in protein losing enteropathies. Nephrotic syndrome, you're losing protein, so you're not just losing albumin, but you're gonna be losing immunoglobulins, you're gonna be losing a lot of those other circulating proteins and smaller molecules when you have nephrotic syndrome. And those glomeruli are just like sieves. And malignancy, and also side effects of medications. So we've learned about chemotherapies and different drugs can affect our bone marrow. You can have either increased IgG loss or decreased IgG production. IgG being a major factor in the blood, but in all tissues. And so you can take a look here. Some of your anti-epileptics, antihypertensive, and your steroids, your glucocorticoids that we use as anti-inflammatory agents, they're going to suppress our immune system. All right, now let's flip over to the cell-mediated side. And we're specifically looking at T cell immunodeficiencies here. So, primary, again, these that don't do well. If you have one of these disorders, you're not going to do well. T cell, especially, fungal infections, some virus, some parasites. And so this is all your cell mediated response. And with that, they tend to be pretty severe because that is a major, otherwise with viruses and some of your more severe like mycobacteria, etc. And so DiGeorge syndrome is one. You probably learned about DiGeorge syndrome in peds. It also is known as velocardiofacial syndrome because of the physical abnormalities that defects that affect the head and the neck, the palate, the heart, etc. But it also, in this particular condition, they don't develop a thymus and parathyroids. So without a thymus, you're not going to have maturation of your T cells. Your T cells aren't going to be functional. So, usually not a very good outcome. X-linked immunodeficiency with hyper IgM. So essentially, again, X-linked again. So it's going to express itself in your males. And what happens is they don't produce your IG, because of the deficiency, you're not gonna produce IgA, IgE, or IgG, but essentially all of your immunoglobulins are gonna become IgM. So your plasma cells, everything's IgM. You're not gonna have your full set of complement there. I shouldn't use the word complement, but your full set of immunoglobulins. You're going to be hyper IgM. Okay. A lot of sinus infections, pulmonary infections, autoimmune malignancy is very, very common. Keep in mind, let me ask you this. why are autoimmune and then malignancies common?
No, I just use.
Now, we're talking about T cell immunodeficiencies. What do your T cells do? Pardon me? Yes, they recognize abnormal cells within our bodies, including cancer cells. And if you lack these kind of cells, you're going to be more prone to developing malignancies. You know, these cells protect ourselves against ourselves too. Remember, they recognize it as abnormal, it's gonna destroy it. But if you don't have them, you're not gonna recognize abnormal cells, even those produced by your own body. Okay. Clearly, your secondary, they also have secondary cell-mediated disorders. And so these are not genetically coded. And obviously, they're way more prevalent than primary deficiencies. Okay, and often you're gonna see significant viral infections, again, malignancies, lymphomas. Okay, and they can be it can be transient or persistent, and it can be cell type specific. So looking at some more of your cell-mediated deficiencies, you have combined, which was on the chart as well, and combined T and B cell immunodeficiencies. And this is, again, quite a diverse group. Multiple genes that can be affected with mutations, and either they affect your lymphocyte development, so either maturation and differentiation, or their response, so their ability to release cytokines or the MHC antigens or any of the receptors, so that if they can't produce the receptors to bind, then they can't. They're essentially there, but not functional when it comes to your pathogens. And so there's some severe combined immunodeficiencies, which 45% is X-linked. And there are 13 different mutations that can be severe combined. And so these patients need a very early one in life will need a stem cell transplant if they're going to survive. Other combined immunodeficiencies disorders, you know, it's less severe. And so because the T cells are diminished, or their function is diminished, but not absent. And so, again, broad spectrum, and there's a couple conditions there: ataxia telangiectasia and Wiskott-Aldrich syndrome. And most of these are probably going to be identified earlier on in life. Okay, if you have disorders in complement, again, primary and secondary. Your primary can be autosomal recessive, autosomal dominant, or codominant. So large spectrum there as well. And it has to do with inappropriate activation as well as regulation of complement. Not so much a deficiency as opposed to activation and regulation. And so this is where sometimes you end up with these glomerulonephritis, autoimmune, hemolytic uremic syndrome, age-related macular degeneration, HELP syndrome, and pregnancy, which you'll learn about in the spring, a little bit later in the spring. Those are all complement deficiencies. There's also a rare but life-threatening hereditary angioneurotic edema. This is an autosomal dominant characteristic or trait that essentially it's an overwhelming activation of complement. And one of the things that we said complement does is leads to vasodilatation of your capillary beds. And so what this does is you have this overwhelming complement cascade that leads to significant angioedema. And when you have that, it can cut off the airway, lead to pulmonary edema, and it can kill patients. So it is life-threatening. And it doesn't have to be, it doesn't even have to be an infection. It can be stress-related. Some of the secondary disorders involving complement. Most of the time, since these are protein-based, has to do with faulty production because of liver disease. Protein malnutrition, those are your underlying main issues. And so, or if you have a rapid like activation of complement and turnover of some of these complement products. And we can see that in different disease processes. So you utilize them too quickly, it's an overwhelming response, et cetera, and then you kind of secondarily deplete it for a while. There are specific disorders involving phagocytes. And remember which ones are your phagocytes. So, you know, it can mostly your neutrophils and monocytes. And therefore it's going to lead to bacterial and some fungal infections mostly. And this is your innate immune system. And so for primary, it's usually through either adhesion or the cytokine production, or in the process of degranulation of those toxic granules that are in the neutrophils. As far as secondary disorders, it's again acquired and it's a broad spectrum, so you can take a look at that. Right, hypersensitivity. Any questions? Hypersensitivity, we've covered this. Before in AMS, we've covered a little bit of it again last unit. Hypersensitivity is, you know, just excessive response, abnormal excessive response to whatever the antigen is, and it ends up causing problems for the host. You know, your type 1 is immediate, and that is IgE mediated. You should never ever forget that, okay? Because that's like always a boring question. And yes, it requires mast cells, your basophils, EOs. There's what you should know, and this is important from an emergency medicine standpoint, is there are two phases of the reaction. You have your primary initial phase, and then there's always a secondary or late phase response. Have you covered management of pulmonary and emergency medicine and asthma? Okay. Why do you always send patients home with like steroids or some kind of, if they have a bad reaction, if it's allergic, why do you send them home with steroids when antihistamines? It's for that late phase response. That's why you do it. You have to recognize that if this was allergy driven, there's going to be a secondary or a late phase response where you get this infiltration of the tissues with EOs and other inflammatory cells. And that can lead to an entire delayed reaction or secondary reaction after you send your patient home. And so the steroids that we give, the oral steroids, it's usually to cover that late phase response. Okay, the initial response is all about the vasodilation and the histamine. Okay, as well as some of that smooth muscle contraction, etc. Secondary can happen later. Anaphylaxis is when you have life-threatening IgE mediated hypersensitivity, and it's histamine that gets released everywhere in the body, and then it can that's going to affect vasodilation, going to drop your blood pressure, right? And then you get all that leakage into the airway, and you end up with wheezing. That's why anaphylaxis. And there's a difference between that and anaphylactic shock. So anaphylaxis is if you have systemic symptoms, and wheezing is a major symptom of anaphylaxis. Okay, shock, anaphylactic shock is when you add the drop in blood pressure. Okay, so any kind of shock has to do with a drop in your systemic blood pressure. So the difference between anaphylaxis and anaphylactic shock are just that. And I think you can now see what the difference is and the severity of it when you go to treat it. Okay. Vital signs are vital. Okay, and then of course, there's always local or atopic reactions, and that's if it's confined to a specific area and wherever the exposure is, as opposed to systemic. So if you ate some peanuts and you just kind of got this weird tingling in your mouth, or, you know, feeling weird in your mouth or something, that's the local reaction. However, if you start to get hives all over, that's a systemic reaction. And you start wheezing, then you have anaphylaxis. This just kind of shows you the different components of your type 1 reaction. And it starts with your antigen and looking at your T helper cell, which is going to release some interleukins, which, you know, 3 and 5, as well as 4. 3 and 5 are going to stimulate your eosinophils and recruit them to the area. Your interleukin 4 is going to then attract your B cell, which then is going to produce your, essentially become the plasma cell, produce your antibody, and then that can be released from your mast cells, stored in those mast cells for the second time you get an exposure. And then you get this massive release of all of these, the histamine, etc. And this does talk about some of the late phase response at the bottom. Your type 2 antibody mediated disorders, you can have, or these are called cytotoxic hypersensitivity reactions. Again, very specific. If you think about them this way, it's very toxic to the cells, and it's either IgG or IgM that attacks whatever the target tissue is. And so there's a couple different pathways listed here. And so, and this shows you the 4 different pathways. It shows you the 4 different pathways for your type 2 reactions to occur. It can be related to receptors on the cells, with opsonization. You can have activation of complement, which then is going to trigger that whole process. And you can have antibody, and you can also have inhibition of the binding of your normal, in this case, neurotransmitters. Type 3 reactions, these are immune complex mediated disorders. the difference between type 2 and type 3 is 2 is really the injury is targeted at the tissue that has the receptor wherever the antigen is on that particular cell. Whereas these are antigen antibody complexes that form in the bloodstream, which is circulating. Okay, and these are often later deposited in different epithelium, like the endothelium or in the kidneys. Okay, and once they get deposited, they activate the complement system, which then is going to cause that massive inflammatory response. With some of your glomerular nephropathies, your nephritis, etc. It's about these circulating antibodies that then get filtered, and then as they get deposited in the mesangium of the kidney, they can then trigger that complement cascade and release and destruction of all those tissues in the area. Okay. Type 3 reactions are responsible for the vasculitis that you see in some of your autoimmune diseases. So, and that includes lupus, it includes some of your glomerular nephritis. And so, we can see serum sickness with your beta-lactam drugs or sulfonamides. And so, yeah. This depicts your typical type 3 hypersensitivity reaction. So the picture here is a blood vessel, and it's showing that the antigen antibody complex forms within the lumen of the vasculature. And then wherever it ends up depositing, in this particular case, it's having it deposited in the walls of the vasculature, leading to the vasculitis. Okay, and if you have that activation of complement within the wall of the vessel, and you start getting that complement that now is breaking down, targeting these different antigens, you're going to get weak vessels. And when you have weak vessels, what's that going to lead to?
Aneurysm?
Pardon me? Hey,
Aneurysm?
well, it could lead to aneurysms in some of your bigger vessels, but in the small vessels, a weak vessel is going to do what? It's going to burst, right? And then what are you going to have? A little purple spot, right? It's a purpuric lesion. So your purpuric lesions that you see with your vasculitides, especially your small vessel vasculitis, okay? This is why. It's because of these, this immune reaction that then occurs within the blood vessel. It deposits within, activates complement, weakens those vessels, and you end up with all these purpura everywhere. All right, we'll end with type 4 reactions. Okay, so type 4. Maybe I shouldn't even start this. Yes, I have to. Okay, sorry. No, I have to, because you're gonna, if you have you covered tuberculosis and that yet? Yes. So your type 4 cell mediated. Okay, so your T lymphocytes, and we talked about this, and it's delayed. So cell mediated and delayed. And so contact dermatitis is one example. But we can also have there's other subcategories. So within your type 4 hypersensitivity reactions, there's 4 different areas. Okay, 4A is really is now what we're looking at, eczema. And we're looking at T lymphocytes that activate monocytes, macrophages. They're secreting a lot of interferon gamma. Okay, and then that's going to induce your monocytes and, macrophages to secrete antibodies that fix complement other cytokines and recruit more T cells into the area. So you get this inflammatory response in the skin. You have your maculopapular exanthem or bullous, okay? And then you have that's type 4B, type 4C are actually cytotoxic responses that occur. And where your CD4 and CD8 cells, those T lymphocytes will secrete perforin or granzyme B. So this becomes important with the cavitation that occurs in the lungs in patients who have active tuberculosis. So remember, Mycobacterium tuberculosis is an atypical bacteria. It's an acid-fast bacteria. And so we need our T cells to actually, attack and destroy this. When they get to that area, it's a complicated process, okay? Because our monophages and our monocytes and macrophages are our first line of defense. If the bacteria gets past that, then the T cells come into play. And when they release these perforin and granzyme, it's not selective to the bacteria. And so what it ends up doing is eating away and destroying the lung tissue as well, the alveoli. So you end up with these big cavitary lesions as a result, and a lot of inflammation around them. Okay, and then 4D, which is very rare, and that has to do with recruiting and activating neutrophils by T lymphocytes that specifically secrete interleukin 8. So your contact dermatitis, that's your typical activation of T1 helper cells, T helper lymphocytes. There's also a hypersensitivity pneumonitis that you probably learned about last semester from Dr. Hendricks. And this is due to people who are in an environment, especially like farmers who are constantly inhaling dust and pesticides and stuff like that. And those organic particles becoming antigens. And so your type 4, and again, you have your antigen, you have your antigen presenting cell, and so they can destroy the cells directly, or they can release various cytokines, and that can cause a lot of damage to the tissues around it. All right, we're done for the day. Thank you. Next week we'll finish up with SIRS and